Welcome to the All About the Medicine podcast with Dr. NOLA Knows. In today's episode, we're going to be discussing sudden cardiac arrest in young athletes. Earlier this week, Bronny James, who is the son of Lebron James, suffered a cardiac arrest during his basketball practice at USC. Sudden cardiac arrest is the leading cause of death in young athletes, and it's estimated that 1 in 50,000 to 1 in 80,000 young athletes die of sudden cardiac arrest each year. Although I don't have the facts on Bronny's case specifically, I'm going to make some inferences based upon the data that we do have from previous athletes who suffered a cardiac arrest. I think that this is a good time to bring something that's very serious and life-threatening to everyone's attention and things to look out for. The two most common causes of sudden cardiac death in pediatrics or young athletes is a genetic disorder called HOCM or hypertrophic obstructive cardiomyopathy and long QT syndrome. These two genetic cardiac conditions are uncommon and they don't have symptoms, and usually the first symptom is cardiac arrest. Let's start by discussing HOCM. So HOCM is a autosomal dominant disorder, which means that if one of the parents is a carrier for that gene, their children have a 50% chance of inheriting that mutation, which can lead them to develop HOCM later on. What's scary with HOCM is that it doesn't usually have any symptoms until it's too late. So this genetic disorder is a problem with the gene that encodes for the muscle of the heart. And it's too thick, it doesn't quite develop right, and then the heart muscle gets large. So when the heart muscle gets large, especially at the bottom called the ventricles, which contract and disperse blood throughout the body, it can lead to arrhythmias or an abnormal heart rhythm in the heart, and then all of a sudden the heart stops. The only way to diagnose this before there are any symptoms is if that person has a family history of sudden cardiac death in a person under 25 years old, or if we know that one of the parents is a carrier for it, then we can do genetic screening. But otherwise, without any symptoms, it wouldn't prompt the doctor to do an echo or an ultrasound of the heart to find that. And if the ventricles have not started to enlarge, then we really wouldn't see anything on echo, which makes diagnosing and finding these things before it happens difficult. This is also why knowing your family history is also so very important. When I do physical exams, especially those sports physical exams, I've done it in urgent care, in my clinic, and other places where I've worked. When I ask that question, usually the parents are like, no, but I've really encouraged them to think about it and ask those questions. I know when we have a death in the family, it's always kind of difficult and kind of weird to ask that, but it can make the difference in what I'm screening for your child. Most children don't have any symptoms of HOCM at all, while some may experience lightheadedness, difficulty breathing, or chest pain. And let's be real, how many children, or especially teenagers or who are active and playing sports, are going to say, hey, I feel lightheaded, or my chest hurts, or I'm starting to feel like when I run, it's hard to breathe sometimes. Teens don't really complain, and especially if they're playing sports. They want to impress you. They want to go to a D1 college, and when they're at that D1 college, they definitely don't want to complain. And also, what do we tell young men? Oh, big boys don't cry. Push through it. So it's not... It's more of a cultural thing, and it's more of that competitive nature, and teenagers just being teenagers. So let's talk about diagnosis. So to diagnose HOCM or hypertrophic obstructive cardiomyopathy, it's usually done with the echo. So an echo is a ultrasound of the heart, and we're going to be looking for increased thickness of the heart muscle. But if they do have that genetic mutation, sometimes if they're not presenting with any symptoms, you're not going to see the increased thickening of the myocardium or the muscle of the heart. So we wouldn't do an echo on every kid that's going out to play sports because it wouldn't show us anything until it actually starts to develop. So if HOCM is diagnosed, especially in an athlete, the unfortunate problem with this disorder is that there's not much that we can do about it. We can give medications to slow down the stress on the heart, but we would recommend discontinuation of playing that sport because the risk would be sudden cardiac death. So this is a career-ending diagnosis, but it's an important one to save someone's life. That brings us to the second most common cause of sudden cardiac death in young athletes, which is long QT syndrome. Long QT syndrome, just like HOCM is also autosomal dominant. So that means that if one parent carries the genetic mutation for it, then their offspring have a 50% chance of inheriting that same genetic mutation, resulting in long QT syndrome. And it has to do with the electrical impulse throughout the heart. Whenever the heart muscle contracts, the contraction starts at the top. So it's the top sends an electrical impulse to the top to squeeze a little bit. And then that impulse is delayed in the middle before it gets to the bottom, so that the top of the heart empties the blood and the bottom is relaxed. And then that blood flow, the bottom of the heart contracts, and then the blood is dispersed throughout the body. So in long QT syndrome, the electrical impulse is pretty long for that relaxation of the bottom of the heart to contraction. Intense stress or anxiety or certain medications can make that QT or that electrical waves longer until it goes into this weird funky rhythm called torsades de Ponce, and then the heart just stops. Very scary, but again, there are no symptoms for this. I mean, you can try to diagnose it with an EKG. So some states, especially, I was listening to some news reports about parents who actually lost children from sudden cardiac arrhythmia when they were playing sports, and they raised funds to have EKG screenings for all pediatric athletes. And I thought that that was admirable. And it's really, really sad because nobody expects to lose a child. But again, the scary thing about this is that you can do an EKG and it can be on the borderline or completely normal. And it can take that one medication or that really intense moment of anxiety while a kid is playing sports or going for a really, really important play or touchdown, and then their heart just stops. I want you to ask more of your family history. I want you to talk to your children about certain symptoms. What palpitations feel like? Oh, does it feel like your heart is racing? I want everybody to be aware of this, and this really hits home for me because I do have 2 children. They are twins. They are boys, and they're 5 years old. And another interesting fact that I learned in being a mother, that medical school is great, but it doesn't teach you everything. Children have a really, really high pain threshold, and they don't really complain. They don't. My son, unfortunately, when he was 3 years old, had a fever, and I thought it was just an ear infection, so antibiotics. And then, this fever went on for like day 8. I started to get worried because it's around Christmas, and he just looked worn out. So I go and take his temperature, and it's up to 104. So I took him to the ER. They ran a whole bunch of tests, and I'd maxed him out on Tylenol and ibuprofen, and it was in the middle of COVID. So I was really not wanting to bring my children into the hospital. And mind you, I'm working in the hospital, and of course I have COVID positive patients, and everyone was so concerned about it being COVID. So everything came back negative except an inflammatory marker called ESR. I talked to the ER physician, and we went over what it could be. And right before discharge, they took his temperature again, and it was right back up, gave him some Tylenol, and we went home. Overnight, my son was so miserable. I had a baby camera in there, and him and his twin brother actually sleep in the same room. So I'm listening to my child kind of talk. And so I go up there, and he is drenched in sweat. His teeth are chattering. And this is now almost day 9, and I am exhausted, y'all. I'm a doctor, and I'm family medicine, so I deal with pediatrics. But when you're in mommy mode, that doctor mode is kind of shut off, or maybe the information leaves your brain. So going back to the ER, I was really, really afraid because now it's 3 o'clock in the morning. And of course, everyone is there with their coughing sick child, and it's COVID. So I'm in tears at this point. I'm tired. He's tired. I went and got some ice packs, and I called a friend. And I vented, and she happened to be a physician, and I'm lucky because my friends are physicians. So she called one of her friends who happened to be a pediatrician at Stanford. So we discussed his symptoms and any abnormal labs, and she said, "Oh, his ESR is high." Well, what did they do, an echo of his heart? And I said, an echo? I'm scratching my head. Now, mind you, this is 3 o'clock in the morning. And shout out to my female physicians, and especially that one because you saved me. But I said, no, they didn't. I didn't even know why she asked that. So she said, look, wait until around 4 or 5 o'clock in the morning and bring him back to the ER. So I go to try to get 45 minutes of sleep. My mother went to lay down with my son and take him in the other room. So I think it was maybe like an hour later. She's like, "Oh my gosh, come and see this." So I run downstairs, and he has these raised bumps all over his legs. His lips are swollen. His gums are swollen. And I breathed a sigh of relief, like, "Oh, thank God. It's not infectious. It's autoimmune." And I know this may sound weird to everyone else, but at least I knew what route to go then. I still didn't understand what the diagnosis was, but I'm like, I could work with this. So I pick him up, and we go straight back to the ER. And as soon as we got there, his temp had gone back up to like 104.9. And the doctor took one look. She came in really quick, and she said, "This looks like Kawasaki's." Oh, my goodness. I felt like such an idiot. So Kawasaki's disease is autoimmune. And basically, for whatever reason, the body starts to make antibodies to the coronary arteries, which are the arteries that feed the heart. And so this is very, very dangerous, because if the arteries of the heart are inflamed, they can end up rupturing and cause cardiac death. And so I am feeling like the dumbest mom, right? Because I'm going to med school. But the statistics show, when I learned it in medical school, hey, this happens in Asian males under 5. My son is not Asian. We are African American. And yeah, he's under 5. So he had a hospital stay. We had to do IVIG, do some more echoes, which is that ultrasound of the heart, and he turned out fine. But I say all that to say, when it comes to cardiac issues in pediatrics, they are not going to complain like that. They're not going to say, "Hey, I think I'm having palpitations," because they don't know any different. So it's going to be very hard to really diagnose this, but it's something to be aware of. So when it comes to either HOCM or long QT syndrome, everyone should take a BLS course. BLS stands for Basic Life Support. So in that course, it'll train you how to recognize severe life-threatening emergencies, how to deliver proper high-quality chest compressions and CPR, and how to use that AED. That's that machine that will tell you kind of what to do and when to shock the heart, and it could save someone's life. I think everyone should be CPR certified, because when someone has a cardiac arrest, you have a good 2, maybe 3 minutes to perform CPR so that you can get the blood flowing so that they don't end up passing away or getting irreversible brain damage. The heart is one of the only muscles in the body that does not get a break, okay? You want the heart to keep beating. And when it stops, you are basically depriving oxygen to all of your vital organs. Everyone should be CPR certified in all schools, as well as recreational places where kids play summer sports. Those places should also have AEDs, and also everyone should know how to use it. There's no point in having the AED and nobody knows how to use it. Thank God Bronny was at practice when this happened, and they were able to do quick interventions, and it saved his life. It really saved his life. And this is an unfortunate event, but I think this brings awareness to something that is very important. AEDs are automated external defibrillators. It's a pretty complex tool, but it basically is easy to use, and it can analyze the heart's rhythm and, if necessary, deliver an electrical shock, or it's called defibrillation, to help the heart reestablish an effective rhythm, meaning a rhythm that will actually cause the heart to contract and move blood through the body as normal. You put those pads on the chest, and it will count down and tell you continue compressions. And what it's doing is it's looking for an abnormal heart rhythm there that it can shock. So sometimes when you're doing CPR, the electrical impulses may not be completely nothing. So if somebody goes into cardiac arrest, it's either flatline, which means there's no electrical impulse and you need epinephrine for that. That's the only thing to restart the heart. Or it can be like torsades de pointe from long QT syndrome before it goes to asystole, which means that it's a funky rhythm and it's so chaotic that it's not coordinated so the heart can actually contract. So if you have that AED and it detects that it's one of those funky rhythms, it can deliver that shock so that it restarts the heart back into a rhythm to where the heart will squeeze again. So this device is very, very important, and it's life-saving. Not all schools have it. I don't know if it's on every football field. And it's not just having the machine, it's also having people that know how to use it. because this is the difference between life and death. And unfortunately, there have been young athletes that have died on the field due to nobody knows how to do CPR, or they didn't recognize that it was a cardiac arrest and have hands on the chest, or maybe not an AED. And all of these are assumptions, because I also know other physicians that have lost children to sudden cardiac death while playing sports. So, and AEDs, again, guys, in medicine, being a private practice owner, I've learned a lot. AEDs are not cheap. AEDs cost in between $1,500 to $3,000, and they must be replaced every 2 to 5 years. And in the grand scheme of things, that's a small cost when it comes to saving someone's life, especially a child, and especially if it's your child. On that note, that's my 2 cents about sudden cardiac death in young athletes. I see that Bronny James is actually out of the hospital. Thank God, thank God, thank God. He is so, so lucky. And to all the coaches out there, all the teachers out there, all the parents out there, all the aunties out there, with little kids, I hope that you guys are aware of these things, and definitely look into taking a BLS course and get CPR certified, because you never know when you're going to need it. Practice it. I think the certification is every 2 years. I'm mandated to have like 5 or 6 different certifications, so I'm just used to always being in a refresher course. But it is life-saving, guys. So on that note, thanks for listening to another episode of All About the Medicine with Dr. NOLA Knows.